Okay, so good afternoon, everyone. My name is Rich, one of the co-founders at BiteMedicine. Thank you all for tuning in on an evening to learn about acute pancreatitis. I'm going to start sharing my screen now, so you can wave goodbye to my face, and I'll touch back at the end, all right? So just to make everybody aware, you can use the Q&A function on this platform to submit any questions that hopefully I'll be able to go through at the end if they don't already get answered as we go through. But without further ado, let's crack on. So aims and objectives for today. Essentially, I'd just like to highlight the importance of the pathophysiology of pancreatitis, how it presents, and that's particularly important for you budding doctors and physicians associates for recognizing it, what investigations you need to order, how you're going to manage it, and then complications, which I think is something that's slightly neglected from the medical curriculum, but is really, really useful to know for clinical practice. And as we go through, for those who haven't used this platform before, we'll be doing some single best answer questions using menti.com. So I'd advise you to load that up on your phone, and I'll give you some further instructions about that as we go. And we'll aim to keep this under 60 minutes because I realise it's a Tuesday. We've got places to be. So all of our slides and recordings will be uploaded to app.bitemedicine.com after this webinar. And if you haven't used the website before, it's definitely worth checking out. We have quite a unique style question bank that uses multi-step SBAs to sort of work your way through a patient journey. And we've tried to highlight the important questions relating to each case. So today's pancreatitis one will be uploaded in the coming weeks as a sort of multi-step SBA for you to try yourself. And if you wanted to learn any more about it, you can use our textbook or refer back to this webinar. So that's a little bit about the question bank, our textbook. So let's launch straight into it. So we only have one case today, but it's going to be a bit detailed. So a 52-year-old male is admitted to the surgical assessment unit with severe constant epigastric pain and vomiting. The pain came on within 30 minutes of eating and radiates to his back. He speaks English poorly as he has recently immigrated from Trinidad, and thus eliciting a past medical history is unsuccessful. But on examination, you find that he is tender in the epigastrium with guarding, and there is a scent of alcohol on his breath. And for observations, you see that he has a heart rate of 115, a blood pressure of 98/76, respiratory rate of 19, SATs 95%, and his temperature 38.2. So just to make sure that everyone's with us, if you just want to use the chat function just to tell me which of those observations are concerning to you. Fantastic. Okay, wonderful. Yeah. I've got some people raising their hand. Wonderful. Yeah. BP, temperature, febrile. Yeah, you're spotting it. Wonderful. Well done, guys. So you also note this when you go to examine his abdomen. Now, don't write in the chat what you think it is because it's going to be our first question. So if you go to menti.com, and I'll show you how to do that now. So menti.com and use the code 41 43 72 8. You will be able to access all of our questions for today's webinar. And the first refers to the clinical sign that was just shown previously. And just as you come in, so the question is going to be, what is the name of the clinical sign shown? Is it Gray-Turner's sign, Fox's sign, Cullen's sign, Auspitz's sign, or Blumberg sign. I'll give you guys just a few moments to submit your answers, and then we'll see what people have voted for. So, fantastic. Okay, so a whopping majority have gone for the correct answer, which is Cullen's sign. So brilliant. We're going to talk a little bit about Cullen's sign next, but just to refer to the others. So from right to left, Blumberg sign is actually the eponymous term for rebound tenderness. So that's pushing down on the abdomen, releasing it, and if pain and tenderness is elicited, then it's likely due to peritonitis. So that's Blumberg sign. It's not really used anymore. Auspitz's sign is just an eponymous term that relates to removal of psoriasis plaques, and on removal, whether or not the patient bleeds. So if they bleed, it's called Auspitz's sign. Said we'll talk about Cullen's in a second. Fox's sign actually does relate to our topic of the day, pancreatitis. This is where you get sort of hemorrhage over the inguinal ligament of the abdomen on both sides, and it's secondary to retroperitoneal hemorrhage. So one to remember there. And Gray-Turner's sign, if anybody in the chat wants to tell us about Gray-Turner's sign, where would you classically see Gray-Turner's? Flanks. Yeah, fantastic. Well done, guys. So in the flanks. So if we go back to our case, let's have a look at what Cullen's sign is. So as you can see here, it's this periumbilical bleeding that occurs. But why do you get that with pancreatitis? So we're going to go back to our preclinical anatomy here. So I've drawn these myself because it was impossible to find these images on the internet. So here we have a cut through of the embryo. At the sort of dorsal aspect of the embryo, we've got the developing nervous system, the neural tube, and then a cut through, you can see the developing gut, and it's attached dorsally and ventrally. And here in the ventral portion, we have the developing liver, and it's connected to the abdominal wall by a structure that in adults is the falciform ligament. So why is this relevant to Cullen's sign? Well, as we develop, we get gut rotation. And as the gut rotates, we start to develop the spleen and the pancreas as well. And in the adult, this is the sort of final resting positions of our organs. And as you can see, the pancreas is now retroperitoneal. Okay, so it's behind these layers here of peritoneum. And there are connections, therefore, between the pancreas to the gut, to the liver, and all the way to the front. And these connections do become fibrosed over time. And so you can call them the gastrosplenic ligament when it connects the spleen to the gut, or the gastrohepatic when it's gut to liver. And so in pancreatitis, when you release pancreatic enzymes that begin to sort of auto-digest the surrounding areas, you get hemorrhage and movement of pancreatic enzymes through this tract, all the way through, and track through the falciform ligament to deposit in the periumbilical region. So that is why you get Cullen's sign in pancreatitis. So just returning to our case as a reminder, some bits that stand out. For those of you that don't know, the surgical assessment unit is the sort of surgical equivalent of the of AMU, or the medical admissions unit. So it's sort of one step on from A&E when you recognize that the presentation is probably surgical. Just for the keen-eyed among you, I've mentioned here about radiating to the back. What condition would we be concerned about where pain radiates to the back that could potentially be life-threatening and could mimic pancreatitis? Wonderful. Yeah. So I'm seeing it here. That's a AAA rupture. So aortic, there's an abdominal aortic aneurysm rupture. So one to definitely consider in your differentials here. So we also note here that he's a man from Trinidad, and there is a scent of alcohol on his breath that might come in use, sort of be relevant later. And just in terms of a memory aid, if you ever get stuck between Gray Turners and Cullen's, please remember that Cullen's sign has a U in it, U standing for umbilicus. All right. So if we move on to our sort of introduction of what is pancreatitis, simply put, it is inflammation of the pancreas. But if you were asked by sort of a doctor on the wards, give us a description of pancreatitis, clinically you could say it's a patient with acute abdominal pain associated with a rise in pancreatic enzymes in their blood or their urine. Okay, that would be a very nice textbook answer. It's fairly common. It's estimated about 30 per 100,000 cases every year. And in terms of its presentation, it's the rule of quarters. So a quarter of cases will be severe. And of those severe cases, a quarter will die. So it does carry a mortality rate that can be pretty high in severe cases. And overall, that mortality rate is about 5%. Risk factors, so slightly different to the causes, which we'll move on to, but in terms of risk factors, just as you get older, you do become more likely to, you become more predisposed to pancreatitis, being of Afro-Caribbean ethnicity, and also if there is a family history of it, because there is an element of a sort of hereditary pancreatitis that is seen. Okay, so I just thought it was worth quickly going through the anatomy of the hepatobiliary system. This may have already been covered in previous webinars, but it can't hurt. So the important things to note really here are you've got your liver that produces bile. Bile is stored via the common hepatic duct into the gallbladder. And then when it's needed in the gut, it gets released down through the cystic duct into the common bile duct, where it meets up with pancreatic enzymes that are released from our pancreas. They move through the pancreatic duct, and they all converge on the sphincter of Oddi and get released into the duodenum for nutrition purposes. So in terms of the pancreas itself, it's got two major functions. I'm sure you'll remember endocrine function, primarily being production of insulin and glucagon, but also some somatostatin. And its exocrine functions, there's a glandular function of making amylases, lipases, proteases, all of which are needed for digestion. We said what the gallbladder does, it's for storage and release of bile. And so in just general physiology, when food stimulus is detected in the duodenum, there is a release of CCK, which stands for cholecystokinin, which literally means sort of gallbladder move or bile move. So it stimulates the movement of bile from the gallbladder, as well as in the pancreas, stimulates that production of enzymes and release of enzymes. So how does this go wrong? Well, irrespective of the causes, and I know medical students and junior doctors are always so excited by the causes of pancreatitis because it comes with a fun mnemonic, but irrespective of the cause, all of the pathophysiological pathways converge with sort of two major things, one being obstruction of the pancreatic secretory transport. So it's sort of a blockage within the pancreatic duct that stops those enzymes getting to where they need to get to in the gut. And secondly, then a premature activation of these pancreatic enzymes that are usually in a pro form. And we call those proenzymes zymogens. And they need to be in pro form because if they were activated within the pancreas itself, they would start to digest the pancreas. And because they do become prematurely activated within the pancreas, this is exactly what happens. But our body isn't naive. It does have a number of defense mechanisms to try and counter this premature zymogen activation. So we have a number of different proteins, pancreatic secretory trypsin inhibitors, so PSTIs, as well as some more generic protease inhibitors that are seen elsewhere, such as alpha-1 antitrypsin and alpha-2 macroglobulin. But it is when we overwhelm these defense mechanisms, you then get this unopposed excessive activation of zymogens, and you get pancreatic autodigestion and further enzyme activation. And that is really the crux of pancreatitis, is this inflammation and autodigestion. And essentially, it's a positive cycle, unfortunately. It's the more inflammation there is, the more enzyme release, and so on and so forth. So I would just like you to just take a little note of these investigations. It may be useful later on. So our gentleman, he has white cells of 16, which is raised in his case. Anything above 11 we'd be worried about. Urea of 22, that's definitely alarming. Creatinine of 200, again, not great. And those are his LFTs, his AST and ALT, or just collectively the transaminases, both of which are raised. So just bearing those in mind, we're now going to go to question 2. So if you kindly go back to menti.com for our next question. So again, the code is 41 43 72 8. And the question is, which of the following causes is most likely to be responsible for this patient's acute pancreatitis? You guys, a couple more moments. So our options were hypercalcemia, idiopathic, alcohol abuse, sting from the Titius trinatus scorpion, or gallstones. Let's see what people are voting. Ooh, very interesting. Okay. I respect the vote for the scorpion, I really do. So the answer is gallstones. Okay. Now, before we have absolute outrage, let's return to our slides and have a little look as to why this might be. Okay, so why gallstones? So this patient had an ALT of 180, okay? An ALT of 150 from the literature has an 85% positive predictive value for gallstone-related pancreatitis, all right? Number 2, he had both raised AST and ALT, which in itself is suggestive of some sort of cholestatic picture, likely gallstones. And finally, if you remember from his history, the onset of pain came on shortly after eating, which is in keeping with gallstones. Sometimes if you have a large fatty meal, that fat is sort of detected in the duodenum, so the CCK release causes mass sort of bile release, and that can cause the transit of a gallstone, which could move down the biliary system and block the pancreatic duct, which is the case here. But if you're not happy with that, then why not alcohol? So despite the patient smelling of alcohol, we shouldn't automatically assume that they have chronic alcohol abuse. And because he didn't speak English very well, we have no past medical history to back up our assumptions here. And just in terms of simple statistics, it's estimated that 50% of cases of acute pancreatitis are due to gallstones, compared to about 20% being caused by alcohol abuse. Now, in terms of males, females, those statistics do get slightly skewed, so that in men, alcohol abuse is more than 20% of the causes. Had the patient's GGT been raised, then I think it would have been slightly more valid to have assumed alcohol abuse. Okay, so let's move on to causes, and this is always fun. So anybody in the chat want to suggest what the mnemonic is for remembering the causes of pancreatitis? I get smashed. Well done, fantastic. It's a very apt one for pancreatitis. So let's just work through them systematically. So I can be iatrogenic or idiopathic. So iatrogenic being a sort of caused by medical intervention, idiopathic being we don't know why it's arisen. G for gallstones. If you're ever quizzed in an OSCE for causes of pancreatitis and everything else goes out the window, please just remember gallstones and alcohol. You will get the 2 points. So the E stands for ethanol abuse or alcohol abuse. The T, trauma. Now this is usually from a sharp trauma, such as knife stabbing or gunshot wound. I apologize for the missing letters there. S, now for the 2% that voted for the Titius trinatus scorpion, I like your style. The patient was from Trinidad, which is where this scorpion is endemic, and there is a number of different species of the Titius scorpion that can, according to the literature, cause acute pancreatitis. But in this case, our patient had immigrated, so it was unlikely that he'd brought that scorpion with him. So, you know, if you hear hoofbeats, think horses, not zebras, the line. So M, we're thinking mumps virus, but just if you can remember the other viruses that are also known to cause pancreatitis, so measles, HIV, Epstein-Barr virus, and hepatitis A. A for autoimmune. Specific ones that can cause pancreatitis are IgG4 related disease and also Sjögren's disease or Sjögren's syndrome. Second S is for steroids. So there's a whole host of different drugs that can cause pancreatitis, but steroids, it deserves its own bracket because I think it's slightly more common than some of the other ones. H is for hypercalcemia or hyperlipidemia. So specifically, it's the hypertriglyceridemia. E is for ERCP, so endoscopic retrograde cholangiopancreatography. So that is a diagnostic and therapeutic intervention whereby you pass a scope down the mouth into the duodenum, through the sphincter ordi, and you can see if there are any gallstones. You can also remove them through using a trowel if necessary. So that one is known to sort of aggravate the pancreatitis or aggravate the pancreas and cause pancreatitis. And finally then D is for drugs. So you can remember the mnemonic VAT, so valproate, azathioprine, and thiazide. So there's some of the more common ones. So I get smashed, really, really helpful mnemonic, and some bread and butter of first and second year clinical, I would argue. So if everybody's happy, we'll keep moving forward. So I've just found an image here. I just wanted to show an example of a gallstone trapped within the pancreatic duct, and hopefully that will help you visualize how you get this sort of backup and duct hypertension that leads to the swelling of the pancreas. Okay, so in terms of clinical features, the symptoms that you'd want to watch out for are severe upper abdominal pain, so that's in the epigastrium, but it can also be in the right upper quadrant and the left upper quadrant. A band-like radiation to the back, and again, as a lot of you commented in the chat, you'd want to watch out for a AAA. consider ruling that out with an abdominal ultrasound if you were concerned. Nausea and vomiting, very common. Being off your food, so anorexia, loss of appetite. Dyspnea, so as we're going to see later on, some of the complications of pancreatitis can lead to shortness of breath. If you lose your exocrine function, so if you're not getting the pancreatic enzymes to where they need to be in the gut, you can result in steatorrhea, so sort of stool that's high in fat content, it can be foul smelling, usually floats in the pan. And patient can also become oliguric quite easily, so a poor urinary output. And then signs, classic things to watch out for: tachycardia, fever, hypotension if they're starting to develop sort of inflammatory response syndrome, possibly jaundice. It might be that they're an alcoholic, or it's possible that it's just, you know, causing, say, a gallstone is causing significant back pressure. They might have abdominal distension and tenderness. And then, of course, our eponymous signs that we've covered earlier: Cullen's sign, Gray-Turner's sign, and Fox's sign. And as a reminder for those who have just joined, Fox's sign being the sort of bleeding over the inguinal ligaments due to retroperitoneal hemorrhage. Fantastic. So, question 3. So if you'd all kindly join me on menti.com, and we can take a look at our next question. Again, the code is 41, 43, 72, and 8. So the question is, which of the following investigations is most appropriate to request to confirm the most likely diagnosis? Is it serum LDH, serum lipase, CT abdomen with contrast, serum AST, or abdominal X-ray? So please submit your votes now. Okay, and the reveal. Okay, this is, I thought that this is how it would go. So we've got 2/3 suggesting serum lipase, which is an example of a pancreatic enzyme, and 1/3 suggesting CT abdomen with contrast. Now, the question is asking which is the most appropriate to request to confirm the likely diagnosis. And the answer is serum lipase. So let's return to our presentation and see why that might be. So to diagnose pancreatitis, official guidelines state that you must have any 2 of the following 3 criteria. So the first one is clinical features consistent with pancreatitis. So just a clinical picture: if they've got epigastric pain, if they're nauseous, vomiting, tachycardic, they've got one of the 3 criteria already. The second is elevation of serum amylase or serum lipase. So these are both examples of pancreatic enzymes, and the elevation must be 3 times the upper limit of normal. And our third criterion is radiological features consistent with pancreatitis, e.g. inflammation or necrosis on CT imaging. So why is serum lipase correct? Well, it's a simpler test than ordering a CT. It's actually not recommended that you routinely order a CT to diagnose pancreatitis when you could simply use serum amylase or serum lipase. I elected not to put serum amylase as an example in the question in case it was too obvious. So yeah, the correct answer there is serum lipase. Now, obviously, if their serum lipase came back negative, as well as their serum amylase, and you were still thinking, I'm pretty sure this is pancreatitis, you could discuss with an on-call radiologist and say, you know, can you vet this CT for me? I think they've got pancreatitis, and it could go through. So yeah, you just need 2 of those 3 criteria. So in terms of bloods you'd want to order, your you know, it's 4 a.m., it's a night shift, you're working in the surgical admissions unit, and you think, oh, what am I going to actually do for this patient? So serum amylase over serum lipase. So most trusts would go for serum amylase. It's more common. It rises faster than lipase, but unfortunately it is less specific. So there are other causes of hyperamylasemia in the literature, common things and rare things. I think one example I've read in a case study was certain ovarian tumors can cause a rise. So you've got your serum lipase as an alternative. It's much more specific, but it's less routinely done. Then the old classics, so your LFTs, so both albumin and your transaminases are required for scoring the severity of pancreatitis, which we'll be coming on to. And FBC, knowing what the white cell count is in a patient is very useful for severity scoring. It can also tell you if they have some sort of concurrent infection. Usinase, so that's urea and electrolytes. We need urea to actually score our patient's severity. Clotting screen. So as we'll see later on, one of the complications of acute pancreatitis is the development of DIC, so that's disseminated intravascular coagulation. So it's important to monitor clotting for sort of progress and development of that. Doing an ABG, arterial blood gas, again, would be required for severity scoring. We need to know what their oxygenation of the blood is. Serum glucose as well for severity scoring, blood sugars. So if the pancreas is blocked and starts to become sort of auto-digest and damaged, then perhaps the ability to release insulin, make insulin, will go down, leading to an increase in blood glucose. Serum LDH, so an alternative to using transaminases, you might want to use LDH. It's just a measure of sort of tissue damage, and serum calcium levels as well would be useful, not only for severity, but also if they're sky high, that might give you a clue as to what the cause of pancreatitis is. As you'll remember from I Get Smashed, that the H, one of the H's was hypercalcemia. Fantastic. And then moving on to imaging that you might like to use. So a chest X-ray would be really important. So you'd want to see whether the patient is developing one of the pancreatitis complications known as ARDS, acute respiratory distress syndrome, as well as pleural effusions and atelectasis. And we can have a look a little bit later about why a patient might develop these processes. An abdominal X-ray. Now, I don't think you would get shouted at by a radiologist if you suggested that you wanted an abdominal X-ray in a patient with a surgical abdomen. If you wanted to just exclude bowel obstruction, I think it would be perfectly valid. And there is some literature to suggest that pancreatitis can actually cause sort of proximal blockages of the gut that can kind of mimic a bowel obstruction. So if you sort of saw dilated bowel proximally, you would, an abdominal X-ray would detect that. And then things to consider: abdominal ultrasounds, you could potentially use it to see whether or not there is evidence of gallstones, and also to rule out a AAA. And then the CT imaging that we discussed earlier. So you'd want to use a dynamic contrast enhanced CT. But as I've said, this is not routine for diagnosis. And things you might want to look for on the CT are local edema and swelling around the pancreas, as well as variable attenuation of the contrast, so certain non-enhancing areas that could suggest pancreatic necrosis, so death of the actual pancreas itself. CT scans tend to get ordered if the patient is not improving after sort of 6 to 10 days, when some of the sort of localized complications may be setting in. And I've just got an example here for you guys to look. So hopefully you'll be able to see my mouse, but if not, the pancreas is in the middle of this CT slide, and just slightly surrounding it, we have this sort of dull layer of fluid. So question 4, you know the drill by now. If you'll head over to menti.com and the next question. Okay, so which of the following would score a point on the modified Glasgow scoring system for acute pancreatitis severity? So we're stepping up the difficulty a little bit here, guys. So we want to know the modified Glasgow scoring system for acute pancreatitis severity. Which of the following parameters would score a point? So is it age 50 or above, a calcium of 2.2, a urea of 20, an LDH of 500, or an albumin of 35? So give you a couple more moments to vote, and then we will reveal. Okay. Okay, a bit of a sort of split vote here. The majority, 34% of you, have gone for a urea of 20. Next highest we've got is an albumin of 35. So let's have a look. And the majority wins. So urea of 20 is correct. So the modified Glasgow scoring system, let's learn a little bit about it and why it's important. So it is a guide for high dependency care referrals. If a patient has a score of 3 or more in the first 48 hours of their admission, they would warrant a consideration for stepping up their care to sort of high dependency or ITU. Now, I really like the modified Glasgow score because once again, it comes with a very helpful mnemonic. This time the mnemonic is pancreas, okay? And each letter stands for one of the 8 parameters that is used to score the modified Glasgow. So just working through it systematically, the P is for PO2. So you get that from an ABG if they have less than 8 kilopascals of sort of oxygenation, then you get a point. They immediately get a point if they're over 55. N stands for neutrophils, but in the context of the Glasgow score, it's actually the white cell count you're looking at, and if it's over 15. The C stands for calcium, and here we're looking for calcium less than 2. So we talked earlier about hypercalcemia being a cause, but we're looking here for hypocalcemia. In terms of renal function, a urea over 16 is a really bad sign. So for those who've attended my AKI webinar, you'll remember that sort of elevated urea sort of out of proportion to a raised creatinine is an indicator of a pre-renal AKI, i.e. sort of reduced blood supply to the kidney, which is what we'd be measuring here as part of the severity index. Enzymes, you've got a choice. You've either got your AST being more than 200 or lactate dehydrogenase being more than 600. Albumin needs to be less than 32 in this instance to warrant a score, not 35. And then blood sugar needs to be more than 10. And we've already discussed why blood sugar can become raised in the context of pancreatitis. My partner kindly pointed out to me yesterday that there's a fairly helpful way to remember some of these numbers. So you've got 2 for calcium, then it goes up to 8 for oxygenation. So that's times by 4. 8 to 16 is for urea, and then double to 32 for albumin. So for sort of people who like numbers, yeah. 2, 8, 16, 32 is quite a nice way to remember. Okay. So the management, this is what you might get asked after you've, wonderfully investigated this patient, and you're going up to your senior registrar and you're saying, I think I've got a patient with pancreatitis and this is what I'd like to do with them. So essentially your management is going to be supportive. So IV fluid resuscitation, I cannot stress how important this is for a patient with pancreatitis. They are at high risk of what we call third space losses. So essentially, due to the inflammatory response that occurs due to pancreatitis, there's increased risk of vasodilatation, capillary leakage, and fluid moving into compartments where it shouldn't. For example, the interstitial tissue, or the pleural spaces, or even into the lungs, or to the gut even. So to compensate for those losses, you need to aggressively manage with fluids. You'll want to catheterize your patient. If you're giving them input, you want to monitor their output as well. And this will be particularly useful to monitor to see whether or not their kidneys are getting adequate sort of blood supply, as well as aid with plotting a fluid balance. Oxygen. So oxygen is a drug. You only need to give it when it's indicated. So if the patient has oxygen saturations from a probe of, say, less than 94% in sort of most cases, then you would consider oxygen. It's a painful condition. So it's very important to manage these patients' sort of symptoms. So use of morphine or some other opiates would be indicated, and you should really titrate the sort of dosage to the severity of the pain that they're reporting. And finally, feeding. So a little bit of controversy in the literature here, but resting the pancreas, so keeping a patient nil by mouth, is not evidence-based. And so actually encouraging eating where possible is actually favorable. It's thought to prevent intestinal atrophy and may reduce bacterial translocation from the gut to the pancreas, reducing that risk of infection as a complication of pancreatitis. So, question 5. If you'll join me at menti.com. So the code 4143728. So the question, it's written quite small on this slide. So the nurses note that the patient's wrist is in a fixed flexion position and his fingers extend at the PIP and DIP joints. So that's the proximal interphalangeal and distal interphalangeal joints. What complication has occurred? And our options are Trousseau's sign due to hypocalcemia, Chvostek's sign due to hypocalcemia, again Trousseau's sign due to hypomagnesemia, Chvostek's sign due to hypomagnesemia, or seizure activity. So I'll give you guys just a few more moments and then we'll reveal the answer. Fantastic. 2/3 of you almost have got the correct answer here. So let's have a little look at the complications of pancreatitis, and we'll also touch upon these eponymous signs that have been mentioned in this question. So, in terms of pancreatitis, I think it's really important to split your complications up into systemic problems, so affecting the entire body, and localized problems. Now, the localized, I would really make sure you commit to memory, because I think they're the things that will fascinate the surgeon, the things they're going to want to talk about on the ward round, and the sort of severe complications that can come sort of 2, 3, 4 weeks after a patient presents with acute pancreatitis. But in the short term, these systemic problems are just as concerning. So hypocalcemia, why does that occur? Well, when the pancreatic enzymes begin to sort of auto-digest the pancreas, they can chelate, they can digest fats in a process called fat saponification, and that those fats chelate calcium and sort of deposit as these calcium salts, thus reducing the serum levels of calcium. And that's what causes hypocalcemia. Now, in our question just there, the two signs that were relevant to hypocalcemia were Trousseau's sign and Chvostek's sign. So Trousseau's sign, it is sort of spasticity of the hand and forearm, usually, that occurs usually when a blood pressure cuff is inflated. So, for example, if the nurse was doing some basic observation of vital signs, they might be measuring their blood pressure, put the cuff on. By occluding the brachial artery, you increase the propensity for a hypocalcemic state to aggravate the nerves. And as a result, you get that spasticity. Chvostek's sign is a little bit similar. Again, the hypocalcemia is irritating the nerves somewhat, but if you are to tap a patient's face, particularly sort of over the cheek, in the distribution of the facial nerve, by tapping it, you are aggravating the nerve further and you get a facial twitch, and that is Chvostek's sign. The way I used to remember them is to say Chvostek, you almost have to twitch your face. So that's kind of how I sort of balance the two. Disseminated intravascular coagulation. We've already talked a little bit about this in terms of investigations that you want to order clotting, but what is it? Well, essentially, when you have a widespread inflammatory process going on, you enter into a prothrombotic state. So you start to clot throughout your body. And as you clot, you actually use up all of your important clotting factors. You sort of empty out the coagulation cascade. And as a result, the end sort of corollary to this is that you actually become at risk of bleeding. And so you can bleed internally, and it's very, very serious. So the top two, I say, think about the modified Glasgow score with them. So you measure calcium in your modified Glasgow score. LDH may be raised in this DIC. Functional ileus, so any sort of collection of fluid around the gut may cause an ileus or a sort of stasis of the gut function. As we talked earlier a little bit about sort of abdominal obstructions in the proximal region of the bowel. And the functional just implies that there's not a sort of mechanical obstruction within the bowel itself. Renal failure, well, this is going to occur due to things like third space losses. So this is where, again, we have our inflammatory response causing vasodilatation, capillary leakage. So there's less sort of fluid volume within the intravascular compartment, which means that your kidneys are going to get less blood supply, and you could enter into a pre-renal AKI-like state. Some further systemic causes, again, some of these link to our sort of systemic inflammatory response syndrome and third spacing. So ARDS is essentially sort of fluid within the alveoli, so you just cannot oxygenate your blood, unfortunately. Pleural effusions, again, sort of third spacing into the pleural compartment. Aspiration pneumonia, so this is essentially if a patient is to sort of breathe in or aspirate their own vomit. Now, as you're aware, pancreatitis can cause vomiting, so you are at an increased risk of aspirating your vomit, and an outcome of this could be aspiration pneumonia. And finally, simply hypovolemic shock. So in really bad cases of severe inflammatory response syndrome, you could get sort of a shock-like state where you're not perfusing your organs properly because you're hypotensive and tachycardic. So they're the systemic complications. The sort of the key ones to know, I think, for your exams are hypocalcemia, renal failure, and ARDS, definitely as some important ones. So before we go into the local complications, we've got Another question for you. So again, menti.com, those who haven't used it yet, 41, 43, 72, 8. So as you guys join, after 6 days, our patient remains in pain. He's pyrexial and tachycardic. And the CT shows variable pancreatic contrast enhancement. The question is, what complication is occurring? So our options here are pancreatic pseudocyst, peripancreatic fluid, necrotizing pancreatitis, chronic pancreatitis, or incidental pancreatic cancer. So you want to just take your time. So it's after 6 days, he remains in pain, pyrexial and tachycardic, and the CT shows variable pancreatic contrast enhancement. So what have you guys put? Very interesting. We're split with a pancreatic pseudocyst and necrotizing pancreatitis, tied at 39% for each. So the answer is necrotizing pancreatitis. So let's have a little look as to why that is. So as we said, we've done our systemic complications. Let's look at our local ones. So necrotizing pancreatitis. It is a severe subtype of acute pancreatitis, and it's usually where necrosis sets in within the first 24 to 48 hours. So within a couple of days, the pancreas will portions of it will start to die. It should be suspected in anyone who continues to have symptoms despite your best supportive management. And the key diagnostic factor is non-enhancing, low attenuating pancreatic tissue on CT imaging. Okay, so if you saw that, if you're suspecting that they may have it, you order a CT with contrast, you get this picture or you get the report back and it says this, it's looking pretty likely. It carries a really, really poor prognosis and has a high risk of becoming infected. So in terms of management, well, you might want to first of all, absolutely confirm the diagnosis with a biopsy, but it may be indicated actually to just do a percutaneous drainage of sort of the infected and necrotic material, or even an open necrosectomy. So that is what our patient had. So in our case, he presented about 6 days, he wasn't getting better. CT was ordered, necrotizing pancreatitis. If it was chronic pancreatitis, so this is just essentially recurrent episodes of acute pancreatitis leading to this chronic picture where your pancreas becomes knackered, essentially, defined as irreversible inflammation and or fibrosis with a progressive decline in both the endocrine and the exocrine function. If for those who use our premium account, we have a fantastic textbook and a multi-step SBA section on chronic pancreatitis that I would really recommend you guys checking out. Then if we move on to our other two complications that were listed in this question, so peripancreatic fluid collections. So the important thing to note here is these occur less than 4 weeks after initial presentation. Essentially, edema in our inflamed pancreas causes the capsules or fibrotic capsule around the pancreas to swell, and you get leakage of pancreatic lipases out through this capsule, and they start to destroy our peripancreatic fat. As I'm sure you're all aware, all of our organs have a layer of fat around them. This fat gets degraded by leakage of lipases, resulting in this peripancreatic fluid collection that's made up of a little bit of sort of degraded fats, also some necrotic material. Not very pleasant. And that would be visible on CT, but usually doesn't really cause any issues and can resolve spontaneously. However, there is an increased risk of development of both pseudocysts and abscesses. So abscesses being kind of infected, walled off collections, and pseudocysts we're about to learn about. So the important reason that pseudocyst was incorrect in our question is because they occur more than 4 weeks after initial presentation. They present with abdominal pain and palpable mass, potentially. Particularly, they will complain of pain if their pseudocyst ruptures or becomes infected. And the reason we call it a pseudocyst is because the sort of walled off material of this kind of necrotic and fluid collection is walled off by either a vascular wall or some sort of fibrotic tissue that doesn't, it's a non-epithelialized wall, which is sort of our definition of pseudocyst. So that is what pseudocyst is. That pretty much brings us to the end of the content for today, but I do have, for those who are interested, a couple of top decile questions for you to have a go at. So if we head over to menti.com. So for those who haven't joined us before, BiteMedicine, we usually do a couple of top decile questions at the end. They're aimed to be pretty tough. And basically, we'll see the question, and then you want to get the question right, but also to be the fastest person to answer. So I can see we've got about 35 of you joining. We'll just wait for everybody else. Wonderful. So question number 1 is coming up. So answer fast to get more points. Which of the following is the falciform ligament an embryological remnant of? Which of the following is the falciform ligament an embryological remnant of? Is it urachus, umbilical artery, umbilical vein, embryonic ventral mesentery, the embryonic dorsal mesentery? We've got 15 more seconds. Time's up. Okay. So the answer was the embryonic ventral mesentery. Very nasty question there. Essentially, it is that connection from sort of our abdominal wall to the liver, and that's, we discussed earlier with Cullen's sign, is what those sort of enzymes and blood can track through to cause that sign. The dorsal mesentery is what is connecting the back of our developing gut to the sort of dorsal portion of the developing embryo. It's not the umbilical artery or veins, and the urachus is the fibrous remnant of the allantois. And for those who enjoyed embryology, the allantois is the canal that drains the urinary bladder of the fetus and actually runs within the umbilical cord. So we have one more question. So question 2. Answer fast to get more points. Which of the following genes is implicated in hereditary causes of acute pancreatitis? Is it c-KIT, MYH7, pancreas 56, P10, or SPINK1? can tell you at least one of these genes doesn't actually exist. I made it up. Five seconds left. Okay, oof, split picture here. And the answer is SPINK1. Okay, SPINK1 is an example of a pancreatic secretory trypsin inhibitor and can be mutated in certain types of hereditary pancreatitis. Just going left to right, c-KIT is an example of a gene that can be mutated in gastrointestinal stromal tumors. MYH7, this gene actually came up in my medical finals. It is a gene responsible for familial hypertrophic cardiomyopathy. Needless to say, I didn't get that question right in my exam. Pancreas 56, I made up. And P10 is an example of a phosphatase that works in cell signaling and is mutated in Cowden syndrome, which is a cancer predisposition syndrome. So let's have a look and see who scored highest today. Results are in. With a whopping 1,807 points, our winner today is Newcastle. Congratulations, very well deserved. Sadly, there is no prize, but you've earned BiteMedicine's eternal glory. So congratulations. So let's, for those who are happy to stay around, I'm just going to return and just do a final recap of today's session. So we talked about acute pancreatitis today. It's inflammation of the pancreas, diagnosed by two of any three criteria. So the three being clinical features, raised serum pancreatic enzymes, be it lipase or amylase, and radiological features consistent with pancreatitis. The majority of cases are caused by gallstone obstruction or ethanol abuse. There are a myriad of much rarer causes that also exist, and you use the mnemonic "I get smashed" to remember them. In an OSCE setting, personally, I would go for gallstones and alcohol before then working your way down to, you know, scorpion bites and hypercalcemia. Yeah, gallstones and alcohol are the ones definitely to commit to memory. Severity of acute pancreatitis can be calculated using a number of different scores, but the most common is the modified Glasgow score, and the parameters of that can be recalled by the mnemonic pancreas. The focus of management is supportive and ensuring early recognition of complications. Complications that I particularly would encourage you to remember: ARDS, that's your acute respiratory distress syndrome; hypocalcemia; DIC, disseminated intravascular coagulation; renal failure; pancreatic pseudocysts; and necrotizing pancreatitis. So we will send out the references with our slides. If you liked what you saw today, I believe we don't actually, I think our feedback form is somehow integrated within this webinar, which is baffling to me, but hopefully you guys can see that. If not, do you know, Instagram us or Facebook us to let us know what you thought of this session. Feel free to match with me on LinkedIn or Twitter. I'm also happy to receive emails about anything we discussed today. I'm just going to quickly look at some of the questions you guys submitted. So in an OSCE station, if you suspected pancreatitis, when feeding back to the examiner, would you mention obtaining both serum amylase/lipase and a CT with contrast just to confirm, or would you just mention the former? So I think to be really slick, you would want to say something like, to diagnose pancreatitis, we need 2 of 3 criteria. The first being clinical features, which in this OSCE station I've elicited. The second being a raised serum amylase or lipase at 3 times the upper limit of normal. If their amylase and lipase were negative and I still suspected pancreatitis, I would discuss with my seniors as to whether or not we needed to order a CT with contrast. And I think that would really complete the package. But if in doubt, it's probably a tick box exercise. So I think just say raised serum amylase will probably get you the marks. Someone asked about explaining third space losses. So I hope I've been able to kind of explain that. But essentially, you know, it's this, when you have a sort of inflammatory systemic response, you are predisposed to vasodilatation, capillary leakages, and your fluid is sort of forced out into different compartments of the body. How does duct obstruction lead to pancreatitis? So if you imagine we've got the sort of tail of the pancreas with the duct going all the way down to where it joins with the common bile duct and entering into the duodenum. Any stone or any obstruction within that pancreatic duct is going to cause blockage upstream of it within the pancreas. So our enzymes that should be leaving the pancreas don't leave, become activated prematurely and start to digest the pancreas itself. Signs of ARDS on a chest x-ray. So essentially you're going to have, it'll appear as sort of consolidation or increased lucency because you've got this fluid within the alveoli. It will appear as a very messy chest x-ray, if I'm being honest, usually in the bases of the lungs rather than higher up. And someone's asked, why was renal failure a complication of pancreatitis? So in pancreatitis, you're predisposed to sort of hypovolemia because of third space losses. And in hypovolemia, you are predisposed to pre-renal AKIs because you're just not getting the adequate blood supply going to your kidneys via the renal arteries because there's just not enough intravascular volume. And as such, you get this pre-renal AKI. So I hope that's been a good session for everybody. I think we're all done there. I look forward to seeing you soon. And if you enjoyed what you saw today, please consider signing up to our website sort of as a premium membership for app.bitemedicine.com. And if you have any sort of comments or feedback on this session today, feel free to write them in the chat or get in touch with us to say what you liked or what you didn't like or what you'd like to see again. But I hope you all enjoyed. And for those that have started clinical placement in the last few weeks, I hope you're having a fantastic time and that the team that you're based with are looking after you and making you feel welcome as you should be. So stay safe, everyone, and have a wonderful rest of your evening.